Hello, Juliet. I am still trying to set up the stream right now. To get the chat working and everything. So give me a quick second. But you came in real fast. That was really quick. Sign in to chat. I guess I need to sign in. Be right back. Let me get my phone. All right, I'm not going to be able to set up the chat, but I think I'll just get started. So welcome to the stream. Thank you, Juliet, for tuning in early. And first, I'm just going to start off with my Anki cards. I only have about 50 to do today, or what is that? Less than 50. I have like 45 to do. And then I'm going to do probably 10 to 15 mix app questions. We'll do some board review and see how I do and see if I can get that. You know, I'm pretty happy if I get like over 80% correct, but I feel like a lot of times I usually end up getting like 65, 70% correct. We'll have to see. Definitely when I've been streaming, I've been having better percentage correct than when I'm not streaming, because I think I take a little bit more time and read through the question a little bit more thoroughly. Hey, what's up, Abradolf? Thanks for tuning in. So let's go into Anki and just do my Anki cards. And let me know if you guys have any questions. But the first one is, are nebulized opioids shown to improve refractory dyspnea in comfort care patients? And the answer is no. So some people try to do like nebulized morphine or things like that, but really you should just be giving them oral dilaudid or oral morphine or even IV because those are the ones that have truly shown to improve comfort for patients at the end of life. What does tonic and clonic refer to in seizures? So tonic refers to this like tensing up of all the musculature, and clonic is that part where they start like having a lot of jerking movements. So increased tone followed by synchronous jerking. Should erythroplakia on the tongue be biopsied immediately? So if you look in somebody's mouth and you see that there is a bunch of redness or like this red plaque on the tongue, then yes, it should be biopsied immediately. You may see something called leukoplakia, where you see like a white plaque on the tongue. However, erythroplakia has a higher risk of dysplasia, and it's commonly associated with alcohol and tobacco use. Is 3-vessel disease that includes a chronic occlusion still an indication for cabbage? This is a card that I made because there was actually a question, and I thought the answer was to stent open the patient. And because there was 3-vessel disease, but there was 1 vessel that was just like chronically occluded. But in general, 3-vessel disease is an indication for a bypass surgery. And even if it's a chronic occlusion and it's like this, like chronically, I guess I mentioned it many times, but if it's this chronically occluded vessel, it still counts as 3-vessel disease. So they should get that, get a cabbage. What is a framework for categorizing the risk of solitary pulmonary nodules? So really, we just try and categorize whether this is high risk, low risk, or intermediate risk. So for low risk, less than 5% risk, we're going to do serial CT scans, just continue to monitor if the nodule is worsening or not. Intermediate risk, we're going to biopsy, and then high risk, we're going to go for resection. And usually, if a nodule is less than 8 millimeters, it's pretty much automatically low risk, whereas anything greater than 3 centimeters is considered high risk. Should you check 25 hydroxy vitamin D or 125 hydroxy vitamin D levels in a patient with hyperparathyroidism? So this, 125 vitamin D is the activated version of parathyroid hormone, of vitamin D. And generally, what we check would be the unactivated version. And this is something that I got wrong on a question, which is why I made this card. So vitamin D deficiency is common in patients with primary hyperparathyroidism due to increased conversion. Supplementation has been shown to reduce PTH levels, decrease bone turnover, and improve bone mineral density. So let's just change that. Can heparin cause hyperkalemia? The answer to that is yes. It can lead to hypoaldosteronism, which leads to hyperkalemia. What is a method to prevent cheeking of opioid medications in admitted patients with opioid use disorder? This is sometimes a concern if you're giving somebody a lot of oxycodone and they're asking for their PRNs every 4 minutes, and then they take it, they pretend to take it, but then they actually just like put it in a bag somewhere so they can take it off onto the street or something. One way you can avoid that is by prescribing liquid medications like liquid methadone or Roxanol, because there's no way they can kind of collect that in their cheek. Are systemic steroids typically indicated for treatment of eosinophilic esophagitis? The answer is no. Usually it's going to be inhaled or nebulized steroids. There's limited data that suggests prednisone may be useful. However, relapse is common after discontinuing. And if a stricture is present, endoscopic dilation is indicated. Should aldosterone antagonists be discontinued prior to screening for secondary hypertension? The answer is yes. They should be discontinued 6 weeks prior. Do you have to be NPO for an MRCP? The answer is yes. You should be NPO for about 4 to 6 hours. Can hydroxyurea cause macrocytosis? The answer is yes. In fact, adherence to hydroxyurea therapy can be confirmed by looking at their MCV. And if somebody has a normal MCV, kind of brings into question whether they're adhering to their hydroxyurea. Should SSRIs and SNRIs be avoided in patients with bipolar disorder? The answer is yes, because there's an increased risk of precipitating mania. Are monthly RBC transfusions indicated in sickle cell patients with a history of stroke? This one was interesting. This is a question that I got wrong, but apparently if somebody has a history of a stroke and then they have sickle cell disease and their hemoglobin's fine, it's like 7 or 8, which is pretty good for a sickle cell patient, then you still do like this monthly simple transfusion, which reduces their stroke risk by 50%. What about a patient with knee pain and lower medial tenderness that worsens with going up and down stairs or rising from a seated position? Initially, I thought that this was patellofemoral syndrome, which is classically, knee pain, especially with going up and down stairs. I think it's more on the lateral aspect of the knee, though. You may have to correct me on that. But knee pain with this one, lower medial, so it's kind of more on the shin area, like just below the knee. This is pes anserine bursitis. So there's severe point tenderness at the insertion of the anserine tendon, about 3 to 6 centimeters below the medial joint, often with local edema. Complication caused by cytokine release after initiating all-trans retinoic acid for acute promyelocytic leukemia. The answer to that is differentiation syndrome, where the patients, all of a sudden, after you give them the retinoic acid, they start getting pulmonary edema and like fluid overload and diffuse capillary leak syndrome and fever, things like that. So prompt treatment with glucocorticoids is indicated. It's not clear whether the retinoic acid should be discontinued or not. What is the preferred diagnostic approach to Lyme disease? This is using a 2-tiered approach. So first we start with an EIA, enzyme immunoassay. And then if that's positive, then you do a secondary test to confirm. Now, if they're having symptoms less than 30 days, you'll get both the IgG and the IgM. But if symptoms are greater than 30 days, you should only get the IgG, and you should not get the IgM because the IgM can be false positive. How does Guillain-Barré syndrome affect reflexes? This causes areflexia or hyporeflexia. This is a very key finding when making the diagnosis of Guillain-Barré. Are patients with psoriasis at higher risk of pustular erythrodermic flare after stopping systemic steroids? The answer is yes. So erythroderma is kind of this diffuse skin reddening like all throughout your body. And so these patients with psoriasis are at high risk after you stop like prednisone or something. When discharging a patient with a smoking history, make sure to remind the PCP to follow up on what cancer screening. This should be a patient with this should be a low dose lung cancer screening, and this is indicated in any patients who are have more than a 30 pack year smoking history and are actively smoking or quit in the last 15 years. Is intranasal tranexamic acid helpful for severe nosebleeds? The answer is yes. This was very helpful because I had this patient that had this like severe recurrent nosebleed that we couldn't control. And so knowing some additional tool in your toolbox besides Afrin and pressure and things like that is very helpful. Should empiric dexamethasone be added for the treatment of bacterial meningitis? The answer is yes, due to potential neurologic complications. If the CSF, gram stain, or blood culture are negative for strep pneumo, then you can discontinue it. This is something that I actually was not doing in my practice, but after reading through UpToDate and all the evidence, we really should be giving empiric steroids to patients with meningitis. What is the recommended duration of low molecular weight heparin after hip replacement? That's going to be 35 days. What is good phrasing to explore why a patient continues to use alcohol despite negative consequences? That's how does alcohol help you? Is topiramate a risk factor for kidney stone formation? The answer is yes. Can IgA vasculitis be diagnosed with serum IgA levels? The answer is no. You need biopsy of an affected organ and then seeing IgA deposits there. What are two ways to estimate if a patient has pulmonary hypertension on CT scan? So one way is seeing that the pulmonary artery is wider in diameter than the aorta, which is not typical, or if the diameter of the pulmonary artery is greater than 2.9 centimeters. Those are two predictive findings on CT that could suggest pulmonary hypertension. What is inhaled N-acetylcysteine used for? It's used as a mucolytic. So if somebody has a lot of secretions and stuff, then we can use that. Does hormone replacement therapy for menopause include estrogen and progesterone or estrogen alone? The answer to that is both estrogen and progesterone, because if you just give estrogen alone, you cause a lot of endometrial hyperplasia. However, if a hysterectomy is present, then this is preferred. Limited systemic sclerosis, as opposed to diffuse systemic sclerosis, is restricted to what areas on the body? That's going to be the fingers and the hands, whereas diffuse is involving the chest, abdomen, forearms, shoulders, things like that. Does Lyme meningitis cause CSF studies that look like viral meningitis? The answer is yes. I got confused because Lyme disease is kind of more of a bacterial infection, but then if you look at the studies, it's high lymphocytes. There's not the typical bacterial meningitis kind of appearance to it. Let me see if this chat is working right now. Oh, my chat is not popping out. So I guess I need to pop this chat out again. And then I can put the chat back in here. Your volleyball video helped me a lot. Thanks a bunch. Yeah, awesome. I'm glad that helped you. Thank you. Oh, I'm not able to get the chat to come up for some reason. Thank you, Abradolf. Yeah, I'm trying to make it so the chat shows up on the stream, but it's not actually showing up. Whatever. I think some of the streaming stuff I'll have to just figure out slowly over time, I'm guessing. YouTube. Oh, there we go. Now it's appearing. Okay. All right. Why is AAI not a commonly used pacemaker mode? So there's different types of pacemakers. This one particularly, there's like VVI, AAI, and DDI. And then AAI is just like atrial sensing, atrial pacing. It's not good because if something messes up the AV node, then you're just literally the pacemaker's not going to work, right? So usually we go for VVI or DDD instead. What are these? Yeah, so these are the three most common types of pacemaker modes. So VVI is ventricular demand pacing. You only put one lead in the ventricle, and it just it just automatically paces the ventricle. So you get this wide QRS, and the problem is it doesn't maintain synchrony with your atrium. This is all very complicated. So like, I probably do need to make a video on this at some point. AAI is going to be patients that, let's see, you're not going to see this one very commonly, but it's a patient with intact AV nodal function. So it'll sense when a signal is being sent in your atrium, and then it'll go through all your normal conduction and then pace your ventricle like that. I'm not really explaining this very well, but DDD is kind of like the best of both worlds probably, because it senses your normal atrial signal and then it manually paces your ventricle. I'll make a video on this at some point. But this is something you can look into and you can read about for sure. Should you test for cure of pharyngeal gonorrhea after treatment? The answer is yes. If somebody has, genital infection with gonorrhea, then you do not need to test for cure. But if it's in their oropharynx, then you do. This is the suprachiasmatic nucleus of the hypothalamus, maintains your circadian rhythm. Indications for digoxin, heart failure, AFib. When is PTU or propylthiouracil potentially better than methimazole in non-pregnant patients? There was some thought that PTU may be better in thyroid storm because it's a little bit quicker onset of action than methimazole. Otherwise, methimazole is almost always preferred, except in first trimester pregnancy. What's the best diagnostic test for a pleural effusion? That's going to be an ultrasound or an X-ray. That's fine. Epinephrine increases MAP and systolic and pulse pressure. What is a non-specific anticoagulation reversal agent used at UC Davis? That's FIBA. It's activated prothrombin complex. And what is the main driver of hyponatremia in cirrhosis? The answer to that is it's volume overload. It's ADH secretion. So kidney feels hypoperfused, so it releases ADH, leading to hyponatremia. What, in your opinion, is the best medication for severe chronic insomnia? Sleep hygiene has been useless. Insomnia is very, very difficult. Generally, medications are kind of like a Band-Aid. And so we don't like to recommend medications for sleep if possible, because it doesn't give the same quality of sleep as natural sleep and also has a lot of side effects, especially for older patients. We worry about side effects like confusion, increased accidents while driving, falls, things like that. So ideally, you should be able to avoid medications if possible. Exercising a ton in the daytime to make sure you're actually tired when you go to sleep is very, very helpful. Sounds like somebody's already told you about sleep hygiene. Melatonin, we always recommend, it's very safe, very low risk of harms from melatonin, basically no risks in taking melatonin. But once you start getting into some of the medications like Ambien, you get increased risk of falls, confusion, sleepwalking, and just like not really restful sleep. And then you start talking about other medications for sleep. Some people use trazodone for sleep, but the evidence isn't super great. Some people use hydroxyzine, which is an antihistamine. Obviously, taking antihistamines chronically is also not that great because it causes weight gain and just cognitive slowing and things like that as well. So ideally, really it is a combination of sleep hygiene, daily exercise to make sure you're tired before bedtime, and then melatonin if needed. Rate limiting enzyme of Krebs cycle is isocitrate dehydrogenase. Okay, I don't need to know this one anymore. What is a medication for alcohol use disorder which has a side effect of weight loss? That would be topiramate. Okay. The other major side effect is cognitive slowing, however. C. perfringens is spore forming and found in the soil. Any tips? So Sang Fan asks, any tips to differentiate Guillain-Barré, multiple sclerosis, Lambert-Eaton, and myasthenia gravis? Yeah, excellent question. So Guillain-Barré is going to be that ascending paralysis. characterized by hyporeflexia or areflexia. And typically, in the question stems, they're going to tell you they had like a recent viral infection. Although people can get Guillain-Barré without a recent viral infection, but usually on your board exams, it's going to be like this ascending paralysis after a viral infection. Multiple sclerosis, the key thing to think of for this one is different lesions that are so lesions that are separated by space and time. And what they mean by that is that if you take an MRI of a patient's brain who has multiple sclerosis, you'll see a bunch of white lesions in random areas. And then you take an MRI next time, and all these lesions are in different locations. And then you take another MRI the other time, and then there's no lesions. So they vary in space and time. That's the typical thing there. But multiple sclerosis, some other key things about that. It can cause any sort of symptoms, but typically you're going to see it in younger female patients, especially of Caucasian descent. And also, they frequently like to test on Lermet's sign. It's Lhermitte. And this is basically when they do flexion, or when they do extension of their neck, rather. They get this like electric shock sensation going down their spine. So those are the key things to think about for multiple sclerosis. And then for Lambert-Eaton and myasthenia gravis, so myasthenia gravis is fatigable. So as you go through the day, your muscles get more and more tired, and they start to get more and more like ptosis and double vision at the end of the day. Also, if you just ask them to blink a bunch, like blink 20 times in a row, then at the end of that, you'll see that there's more muscle weakness in myasthenia. Whereas Lambert-Eaton is the opposite. So they start off really weak, and then they get stronger throughout the day. More classic associations with Lambert-Eaton would be like small cell lung cancer because of paraneoplastic syndrome, which causes Lambert-Eaton with all these antibodies. What is the mechanism of action of triptans? That's going to be a serotonin agonist, decreases neuroinflammatory peptides. Uncomplicated coag-negative staph bacteremia can be treated for 14 days, 5 to 7 days. Okay. AGEP, so acute, I forget the G stands for, exanthematous pustulosis, has onset after 1 to 2 days, I believe. AGEP stands for, I forget what the G stands for. AGEP. Acute generalized exanthematous pustulosis. Test to evaluate if a patient with subclinical hypothyroidism is likely to progress to overt hypothyroidism. That's going to be a TPO antibody. High levels of anti-TPO are associated with progression to overt hypothyroidism. And a nematode associated with vitamin B12 deficiency is rectal prolapse is trichuria. So I got that one wrong. All right, and we finished that deck for now. So let's now move on to some mix-up board review questions. We'll just do a quick set of 10 questions. And as you can see here, I had some good scores, but I've had a lot of middling scores too. So I had 66, 69, 95%, 60% here, but this was 80% correct because 2 of those questions I think were not that good. So let's do a new quiz, study mode. We'll do all specialties. And then we still have 821 unanswered questions. So we'll just do a short 10-question quiz, and that'll be it for the stream. So a 58-year-old woman is evaluated in the emergency department for sharp, non-radiating pain to the left lower quadrant that has persisted for 2 days. So immediately, left lower quadrant, most commonly we're going to be thinking about things like diverticulitis, but also like ovarian things can happen in this kind of middle-aged woman. Abdominal CT shows focal diverticulitis in the sigmoid colon without abscess. So this is now explaining uncomplicated diverticulitis. Which of the following is the most appropriate next step in management? Colonoscopy, IV antibiotics, oral antibiotics, or surgery? A lot of times for uncomplicated diverticulitis, there's actually a lot of evidence that we do not need to prescribe antibiotics for this. So let's make sure she has a colonoscopy recently. She doesn't have any alarm symptoms, elevated leukocyte count. The only thing is, I did recently learn that colonoscopy is indicated for anybody with a recent episode of diverticulitis. However, in this case, she's already had a colonoscopy. The reason you do a colonoscopy afterwards is to rule out that there's colon cancer that's causing the diverticulitis. So in this case, I think in practice, we would probably prescribe this person oral antibiotics, even though the evidence for antibiotics in uncomplicated diverticulitis isn't that strong. But I almost wonder if they're trying to test on repeating a colonoscopy again. Yeah, I feel like in practice we would do oral antibiotics, but I would not be surprised if it ends up being colonoscopy again. Okay, so yeah, I think because she already had the colonoscopy, you don't have to do that again. Yeah, so uncomplicated oral diverticulitis that can be managed with oral antibiotics. Although I feel like you really actually don't even need to. Diverticulitis. So should all patients undergo colonoscopy after an episode of diverticulitis? Yes, the American Gastroenterology Association recommends colonoscopy 6 to 8 weeks after. Let me go to up to date. Okay. Although the use of a 7-day course of oral antibiotics does not shorten the clinical course of diverticulitis, it may prevent complications from diverticulitis. In patients who have not undergone screening colonoscopy within the past 3 years, colonoscopy should be done 4 to 8 weeks after resolution of symptoms. So if it's been 3 years since their last one, then they should get a colonoscopy. So let's see. See, for most patients who are appropriate for outpatient management of acute colonic diverticulitis, we suggest against antibiotic treatment. However, clinicians may choose to use antibiotics in patients who have major medical comorbidities or other problems. So again, UpToDate recommends against antibiotic treatment, but in this case, that was the correct answer. And so I do say that in practice, we do tend to give oral antibiotics frequently for this. A 67-year-old woman is evaluated for slowly worsening fatigue and exertional dyspnea of several months dyspnea of duration with more recent yellowing of the skin, so describing some jaundice. She also has a medical history significant for Hashimoto's thyroiditis, and she's on levothyroxine. So she's got jaundice. She's very anemic. So this is already making me think of autoimmune hemolytic anemia because she's got a history of autoimmune disease. She's anemic. She's got jaundice. It's probably going to be indirect hyperbilirubinemia, which we see here. She's got an elevated LDH. And then, if she checked a haptoglobin would be low. A peripheral blood smear shows macrocytic erythrocytes with rare erythrocytes and scattered neutrophils, 6-lobed neutrophils. A direct antiglobulin test is negative. So this is actually the test for autoimmune hemolytic anemia. So that is actually negative. So now we're going to have to figure out what is causing her hemolytic anemia. Rare nucleated erythrocytes. So these are basically showing that there's like immature red blood cells coming out. I think 6-lobed neutrophils is normal. She does have a pretty high MCV, but vitamin B12 and folate deficiency shouldn't be causing hemolytic anemia. Flow cytometry would be looking for like paroxysmal nocturnal hemoglobinuria, but they are not describing any of that, like waking up with red urine or whatever. Could she have G6PD deficiency? It's possible, but it's pretty rare to have. I think it would be pretty rare to diagnose it in a 67-year-old woman, at least my opinion. And usually they give some kind of trigger that's, triggered their G6PD deficiency, whether it's fava beans suddenly or some different medications like isoniazid is classically associated with G6PD deficiency, showing its head. So for me, I think the most likely one, I think that I'm worried that there's some kind of hematologic malignancy process going on because she's had this going on for several months. She's 67 years old. She meets the age where people start getting malignancies, and the peripheral blood smear starts showing these like immature red blood cells that are coming out. So I'm going to go for bone marrow biopsy, although, my gut feeling would have been like flow cytometry. But let's just see what it is. Oh, it is B12 and folate. Okay, so I was completely off. So let's see. I didn't know that B12 and folate deficiency could cause hemolysis. Okay. So similar hematologic findings. All right. So that's actually a very simple one that I got wrong. Methylmalonic acid and total hit homocysteine levels are helpful in differentiating B12 deficiency versus folate. The way I like to remember it is, so folate deficiency, B12 will have both. So B for both.